My name is Gurleen Kaur, and I'm a second-year internal medicine resident at Brigham and Women's Hospital. Today's interview is part of a collaboration between Radcliffe Cardiology and the CardioNerds. I have the pleasure of being a part of the CardioNerds as an Academy Fellow and the director of the CardioNerds Internship. I'm so excited to introduce Dr. Aruna Pradhan. Dr. Pradhan is a cardiologist at Brigham and Women's Hospital, associate professor of medicine at Harvard Medical School, and associate physician in the Division of Preventative Medicine. Dr. Pradhan's research interests include evaluation of novel inflammatory and lipid biomarkers and novel drug therapy in diabetes and coronary artery disease. He is the co-principal investigator of the prominent trial that we will be discussing today. Thank you so much for joining us today, Dr. Pradhan. Really excited to discuss this late-breaking trial from AHA 2022.
Thank you so much for having me. Pleasure to be here.
So the prominent trial is the randomized, double-blinded, placebo-controlled trial of Pemafibrate, a selective peroxisome proliferator activated receptor alpha modulator in patients with type 2 diabetes and mild to moderate hypertriglyceridemia. We know from the literature that triglyceride-rich lipoproteins likely play a role in atherosclerosis, with evidence suggesting hypertriglyceridemia being an independent risk factor for cardiovascular disease. But there's been differing effects on risk reduction with different pharmacologic agents for triglyceride lowering. Could you tell us a little bit more about the background and rationale behind this trial, as well as the role of different pharmacologic therapies to decrease triglycerides, including Pemafibrate?
Yeah, absolutely. So the trial was designed to test this potent PPAR alpha modulator that's sort of an improvement on the fibrate class of treatments that you may be familiar with, fenofibrate, gemfibrozil, things like that over a decade ago were studied in a population unselected for triglycerides. And the evidence there really was not robust for cardiovascular risk reduction, except in a group that had high triglycerides and low HDL. So we set out to test the hypothesis if you enroll this patient population that has high triglycerides, low HDL, and diabetes, that's a group that's tended to benefit the most in the prior trials, expose them to Pemafibrate, which is a more powerful PPAR alpha, do we get a risk reduction? And I think, why it's clinically relevant is that most US adults get a triglyceride level, if not once or twice in their lifetime, many times as part of a routine lipid panel. So physicians are seeking better ways to treat those patients and lower their risk. And that's what this trial set out to prove, whether or not using this agent in that population works.
That's great. Thank you so much for walking us through the rationale and some of the background. So this is a high-risk cohort of patients with median age 64 and balanced risk factors in the baseline characteristics, and a good proportion of them were on high-intensity statins. Could you expand a little bit about the relevant baseline characteristics and how you think that this applies to the ability to apply these trial results to various patient populations?
Yeah, it's a great question. This was a different population than was studied a generation ago with the other fibrate trials. We enrolled patients, more than 2/3 of whom were on a high-intensity statin. Almost all were on some form of statin therapy, so different than the prior trials in that regard. In addition, their triglyceride levels, the median triglyceride level was about 271, and the HDL level was 33, with an LDL level that was fairly well controlled, 78 milligrams per deciliter. So the trial really looked at add-on therapy in a population that had already pretty good LDL control. It was very high risk. Once we take a look at the event curves, you'll see that within 3 years, 1 in 10 patients enrolled in the trial had a vascular event. So that's way off the scale for any of the risk scores that we think about, really behaving like a entirely secondary prevention population, when in fact it was a mixed primary secondary cohort.
Yeah, that's definitely great to think about that when we think about patients being primary versus secondary, what actual level of risk they are at, and kind of how many events that we're seeing in the trial population. And moving on to the results of the trial. So the trial's primary endpoint was a composite of MI ischemic stroke, and then hospitalization for unstable angina requiring unplanned coronary revascularization and cardiovascular death. And we know from the results that there was no significant difference in any of the outcomes and no heterogeneity across the pre-specified subgroups. Could you tell us your take on these results and possible explanations to explain these results?
Yeah, I think one thing that really is a signal and tells us that we're getting closer to the biology is that there was a decrease, a 20 to 30% decrease in triglycerides, in remnant cholesterol that we all care about, in ApoC3 levels that the genetics tell us we should care about. But on the other hand, there was an increase in LDL cholesterol by about 10%. So 25% to 30% reduction in the TG markers, and then a 12% increase in the LDL markers. That to me, while some may say, okay, the drug failed, that to me actually tells you that the drug was targeting the right pathway, that lipoprotein lipase activity was enhanced, and you got conversion of these triglyceride-rich lipoproteins into LDL cholesterol. That was sort of the cost of lowering triglyceride-rich lipoproteins. I think the next step is really to find therapies that do both, that start the engine, start conversion of TRLs, but then continue to offload the LDL, so clear the LDL. We have a lot more data coming up that will help us tell what counter-regulatory mechanisms occurred when you start degrading TRLs, and that will be forthcoming. But I think the trial itself, although neutral for cardiovascular risk reduction, really is going to be fascinating in terms of what it tells us about biology in these patients and what the next step should be.
Yeah, there's definitely a lot of complexity in the lipid mediators of residual risk in patients. And I think, as you outlined, thinking about the different remnants and what changed in this trial really helps us think more about that. One question I had about the other lipoproteins and apolipoproteins that were studied was that there was not much of an effect on apolipoprotein B. So how do you interpret the study in the context of that? And do you think that there's more work to be done in terms of importance of other lipid biomarkers such as apolipoprotein B?
Yeah, that's a great question. So neither did the total cholesterol go down. So all cholesterol, cholesterol mass didn't go down, and the particles didn't go down. The number of particles didn't go down. So I think that probably goes a long way to explain why we got a neutral finding. Although we had conversion of the big particles to smaller particles, the LDL particles, we didn't clear overall ApoB particles with this therapy. So I think that does have huge relevance. There was a slight increase, about 5%, in fact, of ApoB. It's not a huge difference, but it's not what we hope for. We'd hope for a reduction in total lipid particle burden. Yeah.
Great, thank you for that explanation. And the findings on liver disease are very interesting. Could you tell our listeners a little bit about those findings, and how do you anticipate that will change the utilization of this medication going forward?
Yeah, so what was interesting, and we had some hope from prior data that this drug might offload a lipid accumulation in the liver or resolve NASH or NAFL, non-alcoholic steatohepatitis, or non-alcoholic fatty liver disease. And we collected those endpoints from investigators throughout the trial, and we did find a reduction, about a 20% reduction in the occurrence of non-alcoholic fatty liver disease. And of course, internal medicine docs, GI docs, even cardiologists know that that's becoming a huge proportion of cases of cirrhosis in this country and globally. One of the main etiologies. So that finding needs to be validated, meaning, are these real cases? Are these cases prompted by an LFT abnormality that, causes a diagnosis to be made? Is there ascertainment bias that's introduced because of that, because of post-randomization LFT monitoring, things like that? we need to figure that out. It wasn't a primary endpoint and we didn't adjudicate it. So those are limitations, but certainly if we have another tool rather than diet and weight loss and a few of the other emerging therapies, then it is something that we're hopeful can be pursued and developed for this drug. Pemafibrate is not available in the US. It is marketed in Japan and a few other Asian countries. So it won't be available in the US unless the company decides to go for an FDA approval and a label.
Yeah, definitely would be interesting to see how the drug is used in that and other trials and results that will come off of going off of the exploratory data that you mentioned with the liver disease. So to wrap it up, I know we've talked a little bit about this, that there's been a growing body of evidence about the causal role of hypertriglyceridemia in atherogenesis, and fibrates are commonly used for triglyceride lowering, but this, amongst other trials, now shows us that fibrates might not have any cardiovascular benefit. So how do you anticipate the results of this trial will be used to guide future research in the area of residual risk related to hypertriglyceridemia?
Yeah, so I think the key thing, as we talked a little bit at length, is that conversion is not enough. We need conversion, and the current drugs, it's important to note, don't do that. So, statins don't initiate this conversion from TRLs to LDL. They don't. So we need drugs that do that, but also clear these proteins. So we start this cascade, this lipolysis cascade, and really take advantage of the catabolism that's happening and make it make total atherogenic particles lower with the therapies that come on board. We have the ANGPTL3 inhibitors, the ApoC3 inhibitors. These are really cool mRNA or RNA-based therapeutics that are coming online. They may do the job. We're really looking for that. They have potent triglyceride reduction, 50 to 60%, and some of them also have LDL reduction. So that may be the way to go. I think I want to end with two other things for your audience. The one thing, we did not enroll many Black patients. Reduce it and strength, also two other mild to moderate hypertriglyceridemia trials enrolled 2 to 3% Black patients. I think it's important for us to recognize that even despite best efforts, there is something called the hypertriglyceridemia paradox, in that high triglyceride levels are less prevalent in African Americans than would be expected based upon the degree of obesity, diabetes, and cardiovascular disease. I think we need to figure that out too. What is the reason for that? Certainly, it would be good to have these patients enroll in the trial, but if there's a lower prevalence of this disease in that population, we need to understand why. And then lastly, I think that one of the other key things is that really our trial also showed that you can't rely just on subgroup analyses as post hoc analyses from prior trials. That sort of wishful thinking needs replication and verification in a clinical trial before it's expanded into clinical practice. And fibrates are the second most common lipid-lowering therapies being used across the globe. This does call into question whether they should be used in patients who are already on a high-intensity statin.
Yeah, that definitely leaves us with a lot to think about to guide future research and future work in this area. It's been so great to talk to you about the trial. I want to congratulate you and your team for all your hard work, and I'm looking forward to reading the paper in more detail. Thank you so much for taking out time to talk with us today.
You're welcome. Take care.